Good afternoon. This is Erin with the Department of Medicaid. It's not quite 1:30 and we're still waiting on we are still clearing the waiting room, so we'll give it just a moment before we get started.
Hello.
Hello,
Good
Hey,
afternoon.
how are you?
is that Brenda?
Yes, hi.
Hey, hey, how are you?
Good. And you?
Good, good.
Hey everyone.
Hello, Emily.
Hey Brenda. Good to see you. Hi Melanie.
Hey, how are you?
Do we have any other TAC members on at this time?
Not that I've seen yet, Emily.
Okay. Give it another minute or two.
It is just now 1:30, but we're still clearing out the waiting room, Emily. So if you want to give it a moment longer, I still currently only have the 3 TAC members logged in.
Yeah, let's wait another minute or two and see if Miranda or Arthur join us.
Is Arthur okay? I saw that he sent an email, but I didn't read it.
Well, that's all I've heard from Arthur as well, but I do hope that he's doing better now. It sounded like his fall happened right at the end of May, and he was
Oh,
hospitalized for a few days, so hopefully he's starting to improve. We'll have
I'm
to
sorry.
ask if he's able to join us. Yeah, it sounded like a very scary situation.
Oh, here comes Miranda. I was just getting ready to say your waiting room is clear, but here comes Miranda.
Well, I think four will give us a quorum.
Yes, it does. And I'll keep an eye out for anyone else that is joining.
Right. Hi, Miranda.
Hello.
Good to see you. I'm glad you could join us. With your participation, we now have a quorum, so that's great. And I wanted to just get us started by doing some introductions. I'm Emily Beauregard. I'm the Director of Kentucky Voices for Health and Chair of the Consumer TAC. And I'll just call on our other members to introduce themselves. We'll go in the order of Brenda, Melanie, and Miranda.
Okay, hi everyone. I'm Brenda Menino and I am representing AARP. There is a small percentage of AARP members who are also on Medicaid.
And my name's,
All and important.
yes. My name's Melanie Tyner Wilson. I'm here as a representative for the prior Arc of Kentucky and or the Arc of Central Kentucky.
Hello, I'm Miranda Brown, and I am the representative for Kentucky Equal Justice Center. and a Medicaid member.
Well, glad to have you all on. Aaron, I'm assuming that Arthur hasn't joined us yet.
Not yet, no ma'am.
Okay. All right. Just let me know when he does, if he does. We can go ahead and get started on our agenda. We've established our quorum. The next item here is approval of minutes from our last meeting. Did everyone have a chance to, and totally recognizing that it's a long transcript, but did anyone take a look at it? Any questions or anything that you want to correct before we go for a vote?
No.
Okay. Then I will ask for a motion to approve the minutes.
To approve the minutes.
Thanks, Melanie. And a second.
I'll second it.
All in favor, say aye.
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 Any opposed? All right, motion carries. Just making some notes. Okay. The next order of business is our old business. So the usual standing data requests that we have for the cabinet. Our first is how many Kentuckians are currently covered under traditional, expanded, emergency time limited, and presumptive eligibility Medicaid.
Hi, good afternoon. Hope everybody's doing all right. I've got those numbers for you. This is Jordan with the Department for Medicaid Services Eligibility and Enrollment Branch. So as of today, we have around 1,525 individuals with presumptive eligibility Medicaid. We have 336 individuals with the emergency time limited Medicaid. In total enrollment is 1,446,689. Of those individuals, 459,462 are expansion. In fee for service, we have 150,925. And then in managed care, we have 1,295,764. And I can post these numbers in the chat if anybody didn't catch all of those.
Yes, I would appreciate that.
Yeah, no problem.
I was just going to ask you to do that, Jordan. I didn't get them all while I wasn't typing fast enough.
I got it. Sorry, I was talking fast today.
No, that's helpful. Thank you. Any questions about our current enrollment? All right. Jordan, you probably have the answer for this next one as well. How many households or children received letters in June for renewals that are due at I believe it's the end of July? And then how many will receive letters in July for August renewals?
Hi, this is Veronica Judy Cecil with Medicaid. I apologize because I know I have it in my emails and I'm quickly searching for it. At least I don't have exact numbers. I think we're still waiting for final confirmation of, as you know, the way that our renewal process works. So for somebody that has a July renewal, we run them through our ex parte or our passive renewal, meaning we go out and check all the databases to see if we can renew them automatically. And that happens at the very first of the month before their month of renewal. So that happened in early June, and then that kind of gets filtered down and we look at then sending out the renewal packet for folks that we could not renew passively. So if you could just give me a moment, Emily, and come back to me, I'll try to pull that information out for you.
Yeah, absolutely. No problem.
Thanks.
And I think everyone at this point, if you tune into our consumer TAC calls or if you're a member of the TAC, knows that child renewals are resuming on July 1st, which is why we've been trying to just sort of track this and monitor. And hopefully a lot of families are hearing that news now and preparing to be responsive to any notices that they receive. But that's something that we could use a lot of help with in terms of educating folks. Yeah, and I'll just skip to the next item, which is how many Kentuckians receive 1915C waiver services or are on the waiting list for each waiver.
I do have Emily. I
Okay.
apologize. Go
No,
go
that's all
ahead.
right. We'll go back
No,
to
go
child.
ahead, Veronica. ahead.
Okay. So for child renewals, for July, the number of individual children that we had going through renewal is 9,412. I don't have, though, they did not have available how many of those successfully went through passive renewal. I'll probably have it today at some point, but I don't have it at this time. And then for August renewals, currently the count for individual children is 8,596.
Okay. That's good to know. And so those are children, not households.
That's right. Yep.
Okay. All right. Any questions about that before we move on? It would be great to get the ex parte number percentage whenever you have it.
Absolutely.
I think that tells us a lot about how many families actually need to complete paperwork and helps us be a little more targeted. All right, so back to our 1915C waiver services.
Yeah, hi, Emily. This is Carmen Hancock with the Department for Medicaid Services, Division of Long-Term Services and Supports. I've got that information. So for ABI Acute, we have 270 members. ABI Long-Term Care is 435. Neither of those have waiting lists currently. Our home and community-based waiver has 16,915 participants. Total on the wait list there is 4,873. For Model 2, we do have 15 of those slots filled. There's no one on that waiting list. Michelle P. waiver is sitting at 9,965 participants with a waiting list of 9,576. SCL, Supports for Community Living, 4,998 participants with 3,648 on the waiting list. And I know at the last meeting, people inquired about emergency and urgent status with SCL. We don't have anyone in emergency status right now, but we do have 63 folks on urgent status.
And in that case, when someone is on urgent status, do they get priority in getting the next slot? Is that how it works?
So emergency, and I'm looking to see if there's someone here.
Sorry, this is Leslie. So emergencies first, urgents next, and then futures planning is the third. So we always take emergency first. It's the shortest of term. And then urgent a little bit longer, and future planning is just what it says. I know I'm going to need it in the next 5 years. I'm an aging mom. My child may have a disability. So does that answer your question?
Yeah, that makes sense. Any questions about the current enrollment in home and community-based service waivers?
I'll drop that in the waiting in the chat as well.
Okay, thanks. And probably should have switched these two items around, the 11 and 15 community engagement waiver and the HCBS waivers. Since we're talking about HCBS, why don't we skip to that item next, and then we can go back to the community engagement waiver. So as far as the waivers and the federal final rules go, are there any updates as far as anything changing?
As far as the home and community-based waivers, I don't have any changes right now.
Okay.
Nothing set in stone. You
Okay.
probably know as much as I do about the big, beautiful bill.
Wow. Yes. Lots up in the air.
Yes.
Lots of uncertainty.
So much.
One thing that I did want to follow up on is the review that DMS is doing of the coverage for children or the waiver slots for children who were being denied based on level of care, or maybe there were a few other reasons as well.
Yes, Emily, I've got that. So we did go back and we looked at both youth and adults. Obviously, we sort of were tipped off, having received a lot of feedback regarding children's denials, especially at their reassessments in HCB. So we did go back to the beginning of January and pull any child assessment that had been denied level of care. That it worked out to 151 cases. Of those cases, we've worked through all of them. Both myself, my nursing review team, and then our vendor, we went back and did a second, third, fourth look at all of those children. So what we came out with was we overturned and reinstated services and level of care for 112 of those 151. We felt like the denials were appropriate for 39 of those youth. However, we did go ahead and we've gotten all the correspondence out to both the children's families who got level of care and were reinstated. And then we did have another letter that went out. It went out certified mail to those 39 families that we felt like the denials were appropriate. And we did offer them another option to appeal that decision. So they now have another option to appeal if they want to. Additionally, DMS has put a second level of review in on top of our vendor. For the time being, if they look at any cases and feel that if their team of doctors feels like that particular person is not appropriate for the home and community-based waiver, they are sending us that full assessment as well. And we are doing another review on every single one of those and then getting back to them and saying, yes, we agree, or no, we disagree with your decision. So that's in place for the time being.
So it sounds like that second review is that the providers send the documentation directly to DMS.
Directly to DMS.
And not as an appeal, but just as a second level.
As a second line, so that we can catch them before a denial is even made. So that there's no delay there. There's no holdup or confusion for our participants out there in the community. So
yeah, thank you. We appreciate you doing that.
absolutely.
Are there any questions? Yeah, Melanie.
Yeah,
I knew there would be.
Sorry, no, and thank you, Carmen, for that information. Appreciate it. Just to help to clarify for me and maybe others on the call today, what seemed to be the factor that caused some of those level of cares to be denied. Like there had to be a glitch somewhere that you had to go back and look at them so carefully. Can you give us some guidance in terms of what factors were involved that caused them to be denied? Thank you.
Right. It seemed to be a lot of things combined, Melanie. As Emily mentioned earlier, those child renewals are going to start up again in July. So that was part of it. Sort of children had kind of been pushed through and extended during the public health emergency. And then we found that there was sort of a disconnect with how specifically the regulatory language was interpreted. So we made sure that we shored that up with that vendor so that going forward we are all on the same page with what the expectation is in terms of meeting level of care.
Okay. And the vendor remains the same that's doing that now after all this is that they'll continue?
They are going to continue,
Okay.
ma'am. Yes, I am meeting with them almost daily
Oh.
to work through cases so that when we get through this and we feel like we're in a good spot, we will have worked through enough of these individually together. I mean, we're going through them line by line together, and coming to a place where we really have alignment on our decision making.
Yeah, no, it sounds like it was a very careful review of everything, so I appreciate that. Well, I sometimes get questions from other caregivers, and so I just wanted to make sure I had my act together, had the right information. Thank you.
And Melanie, I will say, just as another layer, I know that you all asked about children's denials. The secretary wanted to be very thorough. So we actually went back and did the same exercise for all adults who were denied as well.
Oh, okay.
So we wanted to make sure that we really got this straightened up and tightened up moving forward.
Okay.
Carmen,
you.
when you mentioned the 151 cases, those were child cases?
18 and under.
Okay. And for the adults that you reviewed, did you have some adults that were also reinstated?
We did. We reviewed 154 adults. That's 19 and over. We reinstated 67 of those and felt like the denial was appropriate in 87 of those cases.
And did you similarly communicate?
We're in the process of getting all of those communications out now. We really focused on working through those children really quickly, and getting all of that tied up. And now we're finalizing all of the adult communications. Yes, ma'am.
Okay. Yeah. Thank you very much.
Mhm.
Appreciate that. Any other questions about the case review? All right. The next item we have here is the 1915I SPA and the 1115 waiver for supported housing and employment. Just an update on where things are at with implementation.
Leslie, you want me to go first?
Yes, Ann, you go first.
Okay. Good afternoon. I'm Ann Holland. I'm executive advisor from the Department for Behavioral Health, Developmental, and Intellectual Disabilities. It's a mouthful. And I'm also the 1915I Rise Initiative project lead for our department. Here's where we are. We are in the final phase of our certification training requirements. We're getting those recorded and we'll be ready to launch on July 1. Our regulations are in final approval phase, yay. We're expecting those they're on target for effective date of July. We're starting media blasts on recruitment of providers to render the service benefits in the package next week. We are, as I said, July 1st is our target date. We're going to start with certification, and then after certification, it'd be enrollment into Medicaid to be provider type 51, 1915I RISE provider. We're targeting mid-July at the moment for a webinar to provide some more details on certification. And I did ask Erin to put our website in the chat as well as an email box for any provider that wants to be added to our listserv to receive, updates as we go. So we've hit the ground running and running fast.
Yeah, that's a great
Can
update.
Can I ask a question?
Sure.
Ms. Ann, do you guys have to go and present this information to the 695 Medical Advisory Review Board? Have you had to go and present this information to them, or are you in a whole different category?
I think we were approved prior to all of that,
Oh.
so I think we're good.
Okay.
Appropriations were in the last budget.
Oh, okay, cool.
Yeah, but good question, Melanie.
Yep.
I do think that any waivers moving forward would have to be approved by Medicaid Oversight and Advisory Board or by the legislature. I'm not sure how specific House Bill 695 was about who specifically would be doing the approval, which has been a question of mine, actually. And if anyone at DMS knows what that process will look like now that we are almost at the implementation of that law. I think it's June 25th, maybe.
Right, yeah, June 25th. No, we are still awaiting guidance on exactly what does General Assembly express authority means, whether that is required to be in legislation, or if a committee or board such as the Medicaid Oversight and Advisory Board is able to approve those.
Okay.
I fear it's it's that it requires General Assembly legislation that, will really kind of bog down our
That
system.
that would be very difficult
Mhm.
for timing,
Yeah, it would.
anytime throughout the year when the legislature is not in session. My hope is that there will be an approval process during the interim. But yeah, it's good to know that you don't have guidance yet. When you do have guidance, I hope that it will be public, that we can also review it. That might be a good topic for a future call.
Yeah, absolutely.
And just so, and I'm, can I ask another question, Emily? I'm sorry.
Yeah, absolutely.
Just to help me understand. So because you all are so thorough when you go through the process to be able to, when you apply for some of these waivers, to meet the criteria that's established by CMS. So, so basically what's happening now is then once you get that approval, then there's a possibility you'll have to still go to the medical advisory review board. Is that correct?
Well, I think what we're unsure of about House Bill 695 is for anything that it's March 30th is when it became effective, that anything that changed eligibility, coverage, or services, which requires that express General Assembly authority. And so we would have to go through that process first before we could then even file something with the Centers for Medicare and Medicaid Services for approval. So that's, as Emily noted, is the concern. Do we have to wait for a legislative session for that to happen? Or can a legislative committee or the new Medicaid Oversight Advisory Board have the ability to give that approval is really what we're kind of trying to figure out. Because otherwise we'll have to wait for a legislative session to get approval for something.
Wow.
And were state plan amendments part of that in the final
Yes.
version?
Yeah, it's for any new waiver and any state plan, any new or amended waiver and any state plan amendment. Yeah, so very, very challenging.
Yes. Well, we'll look forward to any updates once you get guidance. Any other questions about that? The next item we have here is somewhat related because it's about permanent supportive housing, but we know that there's some work on the Continuum of Care Alliance and just wonder if there's been anything recent that you all have been working on with the Kentucky Housing Corporation or other groups.
So Emily, I'll speak to that real quick. I double checked with Jody Allen. She's been kind of leading that initiative. Right now, our housing work is really more focused on the 1915I SMI, of course, the RISE. We have expanded not to just meeting with KHC, but now we meet with all three continuums of care in Lexington, Louisville, and the balance of states, which is KHC, to align, starting to align those 1915I tenancy support services with housing coordination entry process. So you've got, we've been challenged before, and we're being challenged again. We're trying to implement a community program and requirements with our state system, and it's taken a lot of work, and we've got a lot of invested people. We've been working for quite some time with especially KHC. We have a really good vested interest in getting that up and going. And I can give you more later if you want to. As we roll out RISE, they will become, more visual in what we're doing with the tenancy supports.
Leslie, I would just add that right now, my colleague and Jody are meeting with Lexington's COC leader at the same time. We had to divide and conquer meetings today. So we're just trying to align their process with ours and where it interjects and how we can work together in alignment. That's what we're working on.
Sorry, didn't mean to interrupt
No,
you.
go ahead.
I would like to understand that a little bit better. So you're trying to understand how the continuing care
coordinated
organizations
the
are
coordinated
doing
entry process. I'm sorry, I keep cutting you off,
coordinated
Emily.
entry process. Okay.
Yeah.
That could be a good topic for a future call so that we can
And
understand
how we've set up the I process and how it intersects, or how can we string, we show how where they come together, if that makes sense. That's what we're working on with each of them now. And I do believe that KHC has a consultant who's going to do a sort of a Medicaid academy to kind of help some of the providers, and not just some of them from Balance of State. I think they're going to also open it up to Lexington and Louisville's providers to maybe come and learn, because you're talking about people that have never enrolled in Medicaid before, who don't know anything about billing. And so it's going to be a huge learning curve for some of those housing providers that will
Right.
do these services.
And we were lucky to get connected with that consultant. We're not covering that in cost. She's leveraging her existing contract with the state to assist us. So very
And
good integration and leveraging of each other's work.
and I think my department has some funding that they're going to add to that, so that we could have more providers in that. But don't hold me to that. I need to double check that. But I did hear Jason Bagley say that, so I can follow up and let you know.
Yeah, that would
Thanks.
be great. Thank you.
Emily, I wanted to let you know Arthur has joined us.
Oh, great. Welcome, Arthur. Glad you can be here. If you are able to unmute and introduce yourself, please do. But if you're not, we can move ahead.
Ah, 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 ah. Hello, I'm Arthur Junior, Arthur Campbell Jr. I'm representing protection and advancing on TAC. I want my issues to be put on August TAC meeting.
Yes. Okay, understood, Arthur. Really glad to see that you are back in your wheelchair and able to join us today. I'm so sorry that you had that fall and have had what sounds like a kind of difficult month. But yes, we will absolutely add the agenda item about having personal assistance covered when you're in a hospital, or perhaps in other out-of-home places where you're residing for a number of days. We'll put that on the agenda for August.
Hey,
Thank
Emily,
you.
Yeah.
sorry to interject. Just Arthur and I have been I've been communicating a little bit about this issue. Let me find my camera. Sorry. And I sent the one document into the email that he sent earlier where the PCA is allowed. But right now, they're I think Medicaid, and Leslie maybe can talk more about that in terms of with they've have other proposed amendments and are asking for comments, and that's actually going to be removed. So I fear July
Yeah.
because
Too late.
it's due in July 1st, I believe. So just want to point that out to you all.
Thank you. Arthur, I'm comfortable with covering it on today's agenda if you'd like to bring it up.
You ready? It says not ready.
Okay. Okay. Well then, it may be that, just between you and DMS staff over email, or, outside of this call, you can address some of these issues before July.
Emily, I did want to let you know I went ahead and sent that to upper management, so they were already looking into that for you
Okay,
guys.
thank you. And just keep me posted if there is a role that the consumer TAC can play, let me know. If not, we'll revisit this on the August agenda.
Thank you. Thank you.
Arthur, we were just we had covered the new RISE waiver for supported housing, and we're moving on to the 1115 community engagement waiver. That's where we're at in the agenda.
Okay, Emily, I'm on, and I'm forgive me, I have an extremely busy couple of weeks, but I've pulled together a couple of things I just wanted to show you today, and I'll make sure that you get those. But they're kind of here and there. So I wanted to also give you an update on the child's waiver today, if that's okay.
Yes, please.
So as many of you know, DMS is in process of developing the 1115 community engagement demonstration proposal to submit to CMS. And as part of that process, CHFS would just like to express our gratitude and our appreciation for the individuals, the providers, and the advocacy agencies and organizations that took time to review the proposal and to submit comments to us. We were happy to see that many backed the design, right, of the community engagement that we proposed. I think if the design had been different, the comments might have been different, but we did get mostly positive feedback. So if you can see my screen, in compliance with federal regulations, CHFS conducted, can you see my screen okay, Emily?
Yes.
Okay. As part of the federal regulations, CHFS conducted a 30-day public comment period from May the 13th to June the 12th. And we also did a virtual public forum on May the 22nd and an in-person public forum at the Transportation Cabinet on May the 23rd. We have received the comments and inquiries via email or post-mailed through the 12th. Just to let you know, we did have 187 attendees at the virtual forum that was held during the MAC meeting, and we had only 2 that showed up to the in-person. So just wanted to let you know that. We had, so that's 189 attendees with unique public comments of 42. So what happens with those public comments, we'll combine them to similar or alike questions. And then that's how we answer the groupings. And then we'll get those compiled and put back with the application that will be later posted and also sent to CMS. And then I've got one more slide here. For the community engagement timeline, next steps, like I just said, we'll be compiling, summarizing, and responding to the public comment. We'll incorporate the summary of the public comment of the changes to the 1115 demonstration proposal, and we will submit the demonstration proposal to CMS on June the 25th of 2025. We are on target for that. We are currently right now doing internal reviews and have that completed. We are working diligently with the Department of Workforce Development, with Commissioner Yoder and Deputy Commissioner Michelle DeJean. So all of those processes are in place. Just wanted to let you know those pieces. And then on the children's waiver, let me just skip over just, if you don't, I'm sorry.
Before we move on to the children's waiver, just a quick comment. Kentucky Voices for Health, we collected 55 comments in addition to ours. And I feel like in past, those have been captured separately. We did submit them in a combined sort of format, but hopefully those will be, used and kind of
Sure.
summarized in a
appreciate you
way, not
appreciate you
just as
sending those
one
as well.
comment.
Appreciate you sending those. I'm just going to go over, you may be aware or you might not be aware. I just wanted to share with you that the child CHILD waiver 1915C went out for public comment yesterday. CHILD stands for Community Health for Improved Lives and Development. And if you will allow me to, I want to go over just a couple of things with you on another slide. I feel the need to go over this just for 2 seconds because there's been, it's confusing, the processes. The Family First initiative by the Secretary, which is a wonderful, much enlarged continuum of our original mindset of what we want to do here in Kentucky for the continuum of care for children. It's a comprehensive multi-year initiative aimed at enhancing the existing care system of care for all children and youth. And so we've been through, and I'm not going to go through all this because you've heard me talk about these things before. We've got SHINE, which is a grant that we have, the Kentucky Cares, which is the Consolidated Appropriations for Youth grant that we also applied for later. We've got the Children's Health Initiatives that was something we completed on our own so that we could leverage that in a way to compile all the programs in the state of Kentucky for children, and then leverage that when we're asking for grants and programs, and to continue services that if maybe a sister agency or Medicaid had a grant and it's ending, maybe somebody else could assist with that, and to leverage our dollars and blend and braid funds. funding modernization, and then you're going to see high needs service delivery, and this is the 1915C child waiver. It's designed to meet the child-centric care, support services, housing, custody, and placement, and other health-related social needs. But the key component of what I mean on the high needs, it's the highest acuity children. So this C waiver is to fill that gap. Now, it is our plans for that not to be the last task. Of course, we would need appropriations in the future, but our next plan would be for a child state plan amendment after this. And of course, again, like I just said, we'd have to have appropriations. Let me go over this just one second. What is the 1915C child waiver? As I said before, it stands for Community Health for Improved Lives and Development and it's called CHILD. Child waiver is a new Kentucky Medicaid program designed to help children and youth with significant behavioral health or developmental challenges to get services they need while staying in home, in school, and in their communities. It's currently out for public comment right now, and public comment goes through 11:59 on July the 25th. And we still have a target date of August the 25th for submission. So of course I can't answer because this one is actually in public comment. I can't answer a lot of questions today, but I'll put the link in the chat when I'm through, the link to the public comment. And of course it's the same process we always have, Emily. You can email, we actually have a phone number for this one because it comes out of our long-term services and support. So we have the waiver help desk. We also have just regular mail that you can mail it as long as it's postmarked by the date needed.
Well, thank you. I'm glad you did end up presenting on this because since it came out yesterday, I hadn't put it on the agenda, but
yeah, I know. I thought I might have some questions
it's
today.
very timely.
Although I can't answer a lot of questions, I wanted to make sure that you had some. Let me skip down just one
Well,
more.
you know, I do have one question for you, and I
Yes.
understand if you can't answer it, but I don't think it's about the substance of the waiver. So,
okay.
Just to clarify what you said before about needing appropriations, am I understanding that while you're pursuing this waiver, you're pursuing, you know, the approval of CMS to provide these additional services? Will services only be provided if there are appropriations made, or do you have some amount of funding to do that regardless?
So the high acuity needs, the 1915C is already in the budget for fiscal year 26.
Okay.
I have got 1 year for the C, but we would like to you know, request appropriations in the future if that all works out, and to look at like the next steps. Right, this is not the end of the continuum, so I just wanted to let you know that. I think that's it. Oh, I was going to go over just real quick. You'll see this in the public comment. These are the services. Now remember, we don't want this to overlap. This is for high acuity need children, right? When we don't want the services to overlap with any other initiatives that we have going on right now. So we have case management, respite, community living supports, all pending CMS approval, of course, environmental and minor home modification, clinical therapeutic services, and supervised residential care. Remember that this is an HCB waiver. So all those things related to heightened scrutiny, no more than 3 people in a home, all of those will apply to this HCBS waiver. And several of the federal final rules that we are in the midst of addressing now.
Emily, can I ask a question?
Yeah, go ahead.
Okay. Dr. Hoffman, will it be kind of, once it's approved or receives appropriate blessing, will it also be sort of shared with like Part C or EPSDT, you know, so people begin to consider this option as they maybe connect with children in our state that need supports?
Yes. So once we get CMS's approval, of course, we could implement, and then this is a smaller, this 1950C waiver is small. It's only 100 slots. And based on the funds that were allocated in the budget. So again, this is to fill a gap for high acuity needs. Did I answer your question, Melanie?
Yeah, it's just, and I love that you've got something to fill a gap. I wish there were more spots.
I know.
I'm sure there's lots of very appropriate children that would be appropriate referrals into this program.
Right.
And say that they go through this process and they're not included or accepted or recipient of the services, where would they go then if they still have high enough need that there's a desire to provide a level of support?
So, Melanie, I can't answer those questions today.
Okay.
We are trying, like I said, trying to fill a gap in the continuum of our vision for Families First. We're very lucky, and because I work with a lot of other states, we're very lucky that we're going down this path for a full continuum in Kentucky, or doing our best to fill the continuum with all of our sister agencies. So the Department of Behavioral Health also is working with us in collaboration on the 1915C as well. So, and DCBS, we've all been working on these projects together. So we don't let anything fall through the cracks. So there's more to come on this, but listen, this is the same thing as when we talked about community engagement before. Voice your opinion, get out there. Like I said, I appreciate you all doing this before. Get out there and put your comments in for us so that we can gather those and that we have those to go forward with. So I appreciate your time, Emily, to let me also explain.
Absolutely. There is one comment in the chat, and I think that this is similar to what Melanie just asked, or it's really a question in the chat. Since you may not be able to answer that question today, if it's submitted through the public comment period, would you be able to provide a response after the public comment period is over?
Let's see. So what we do after the public comment is to send it to CMS for approval. We usually wait to see what CMS is going to say, because they might not approve something we've got in there, right? Or they might change the language. And then I've got language out there that's confusing to the public, right? That's what we usually do. Okay. But I can keep you all posted as we go. We are hoping for a go live. If everything runs smooth, we're hoping for a go live somewhere early of 2026.
Okay. That's good to know. Thanks.
Yes, ma'am. That's it.
Thank you. The next item here is actually still related to that, overarching continuum, the school Medicaid grant implementation, which I think you all are calling SHINE. Yeah. Just wondering what updates can be shared, and I have a few specific topics there.
Erica, are you on?
Yes, ma'am, I'm on. Erica Jones, Assistant Director in Healthcare Policy, and oversee the SHINE grant. And so one of your bullets is the mapping and models of service. We have identified that there's 3 different models of delivery of school-based services. One is that the schools or the school districts employ the providers and the school districts do the billing. The second would be that the school districts contract with community providers, but the school districts still do the billing. And then that third model is the schools contract with community providers and the community providers do their own billing, and the school is not billing for any of those services. We did send out a survey last year to every school district asking them which model did they use. And what we got back is not what we expected. We thought they would just check one, and a lot were checking, several. So they're using different models depending upon what the service is. So we knew that we needed to do a deeper dive to see what the school districts are actually doing. And so we're looking at the claims, and we have identified 21 school districts that we're going to interview. And so the first set of school districts do not submit any claims for any school-based services. So we're going to interview each of these small sessions to find out who are they contracting with? Is it that they don't know about expanded access? What is their reasoning for that? And then we're also going to interview, we've identified 5 school districts that bill for a lot of the IEP services. They're very, very high school-based services billers, but they're not billing at all for expanded access. And then we have some that are billing for IEP, and they're also billing for expanded access, but not really taking full advantage of it it appears they're not taking full advantage of what is available to them. So we're going to do these small sessions interviewing these school districts. And what we hope to get from that is determine some best practices. Right now, we don't have a lot of guidance and information out there for school districts on what the models are, what is working best for some of their neighbors. And we want to actually have some best practices that we can put out there and help the school districts in determining which model of delivery of services is most beneficial to them and their students. And then your other bullet on the agenda is about parental outreach. Let's see here. So we're starting our second year of the grant July 1. And within that first quarter, we're going to develop an outreach plan. And that has 3 different goals. One, to determine what our target audiences are. We know that parents are going to be one. We know students, as much as we can, would be a separate one. And then school staff, and then the school providers as well. And then we want to know, like, what are the different platforms that we can use for that? If it's social media, if that works better, if it's, hard copies, flyers that we're sending home to parents, radio, whatever media works best. And then we want to develop that outreach content and use some of the things that we've learned work best from other things that are already happening. Maysville Police Department has done some community co-response initiatives with the grant that they had. We also have Jefferson County that had a parental engagement, I will say, project promoting school-based mental health services. That was the Untangled promotional campaign. And so looking at different things that have already occurred and what works best, what didn't work in those, and ways we can maybe duplicate some of those across the state. And then with our social media campaign, we also want to think about, we know for Medicaid, Facebook is the most used of those. Are there things that we could do on Instagram or on X or YouTube, LinkedIn? LinkedIn is really popular with our providers. And just thinking about all the different ways that we can engage all of the community. And then we want to have some FAQs that are like fully established, that are easy for providers to find, for parents, for students, for any of the school staff. And those would all be housed in a central location. So we have right now our kidshealth.ky.gov website. We are hoping that that will be that central location for all things school-based services, but also some of our other programs, our EPSDT special services, and then any other programs that the cabinet would like to highlight.
Great. That's a great overview. Thank you. It sounds like you all have been doing a lot of work. One other question, you had mentioned some of the school districts that you're going to be interviewing. As far as LEAs, if I'm remembering correctly in your application, you were going to maybe select a handful of LEAs to work like most closely with. Have you done that yet?
We have. When we did our, during the needs assessment, we identified several that were highly engaged through our school-based services work group, or who were like the go-to if another school district was interested in expanding access to care. They were the ones that other school districts would go to. So we have worked very closely with several, but we're hoping to pull more school districts in and have those discussions. We want them to be more engaged as well. We don't want to rely on just a handful because we know it varies community to community.
Is that a list of school districts that you'll be able to share or update
Yes.
us on as it grows? Okay.
Yes, so we have sent out the invitations to all of these school districts to do the interviews. We don't have responses back from all of them just yet, but these are the ones that we've identified to interview, and I can share that information. And we have asked that they include, when we're doing the interview, their superintendents, their providers within the school districts, also their directors of special education, because they most often oversee school-based services. So there's a myriad of folks that we want from each district to participate in those interviews, because they all have a little piece of that school-based services.
Right. That makes sense. Any questions? Well, I'm excited to hear what you learned from those interviews. I really do think that having some better guidance for schools is going to help them to get over that hump, whatever it is kind of in their way to providing more of these services. So I think that sounds great, and would love to work with you on the FAQs at some point, or outreach plans, particularly to, parents and students whenever that is, whenever that the time comes for that.
Thank you.
All right, our next item here is language access. We had talked about the one pager on our last call, but didn't have feedback ready for DMS. I wanted to revisit that, and I'm wondering if we could pull up the one pager. I can do it if I need to, but if you have it ready, if someone at DMS has it ready to pull up, that would be great too. And Miranda, I don't want to put you on the spot, but if you've had some time to think about this, I'd love to hear any recommendations that you have for making improvements to the one pager. I've reviewed it again and had a few other people look at it with me, and so I have some ideas too.
Yeah, thanks. Yes. So the one pager, it's great. I like how visual it is. In the middle, where it says how the process works, it refers to in-person translation services. And from the context, it sounds like that should actually be in-person interpretation services. Interpretation and translation are just technical terms in the field with precise meaning. So interpretation refers to oral and translation refers to written. And so I just want to make sure those are really clear on the one pager. And it could even be helpful to include the definitions of what those are. So to explain if and how providers can go about getting MCO assistance with written translations if that's necessary as well.
Yeah, I think that's an important distinction to make. And then the difference between in-person interpreters and over the phone interpretation, or virtual interpretation, I think is another one where, while making the request for an in-person interpreter, I understand does take time to, find that individual, to have them scheduled and make sure that they're available for an in-person appointment. But to do phone interpretation, which happens pretty frequently and is a good, alternative whenever you don't have the time to schedule that in-person interpreter. I think having more information about how to get that phone interpreter would be really, really helpful, because not everybody has the time to wait or to make this request 5 or 6 or however many business days in advance, which I think is lower on the one pager. And having those two options for providers, I think would be helpful. My worry is that if we are only telling providers that they can request these interpreters to be scheduled with 5 business days in advance, that individuals who need interpreters are not going to be offered as many appointments, that they're going to be limited in what slots are available to them because they need so much advanced notice. And this, of course, wouldn't work for any urgent need or walk-in or same day kind of appointments. I would like to see too, the way I read this, the phone numbers that are provided are to just schedule the interpreter. I think if there was a language line number also provided, that would help, so that, when a provider has a patient there in their office, they need an interpreter, they can call the language line. And while on past calls, I have suggested, asked that there be one language line that DMS uses, and you can, get, as one of the screening questions, the language line could ask for a Medicaid ID, and then you could bill appropriately to any of the MCOs. I remember that being, what I remember is that DMS didn't think that that was possible. I still think that it would be a great thing to pursue if you could figure out how to do it with the MCOs. But if, as an alternative, having 5 language lines listed, I think would be a good thing.
So as the alternative, you're saying to list the language line appropriate for each MCO.
That's right. I think you have one number to schedule in-person interpreter and one number for a language line for each MCO. That way, it's just not realistic that you're always going to have 5 business days in advance. And it's not always realistic that you're going to get that interpreter scheduled for certain languages in person. So you may end up needing to use a phone interpreter anyway, for certain dialects or, just a less common language, depending on what part of the state you live in. So I think having those 2 options would be really, really helpful.
Agreed.
And then this is, of course, for providers. I think it could be easily adapted for patients, for Medicaid members. And that would also be helpful to have 2 versions.
I agree. And as we were starting the meeting, I went ahead and sent my suggestions on what could be included in a consumer-friendly version. But I can say them in case there are other commentaries on it. I think it should include some specifics. I think a lot of consumers may not fully understand what is covered in language access services. So being specific that it covers in-person, telephonic, or video interpreters for spoken language or sign language, written translations of what kinds of documents, does this cover accommodations for patients with disabilities? I think some specific language could be helpful for the Medicaid members. And then a phone number to call to request interpretation if their provider does not directly assist them with that, or if the provider refuses, or if there's some issue in getting that help from the provider, some number for the Medicaid member to call. And then I think, just like when you receive your packet from your MCO or your explanation of benefits, and the last page has a statement in multiple languages about, how to call to get the document explained to you in your preferred language. I think that this one pager, it would be helpful to include sample language to request the language access services. Like, I prefer to speak Spanish. I request an interpreter for Spanish, and then have that in which a series of multiple languages so that people can see the English and know what it says, and just helping people even phrase the question of how to ask for an interpreter. I think it is true that a lot of people that are in this country that qualify for Medicaid can at least say, I speak Swahili, I need an interpreter. But it's not, if they're very new to the country, or if they're, maybe in a traumatic situation, there are lots of reasons why it can be hard for people to translate that, if it's not their native language. So having just that translated in the top languages for Kentucky, on the bottom of the one pager or the back, I think would be really helpful. And then just like this one pager for providers, suggest a timeline for requesting language access services. And like Emily said, on-demand services still being available is important. But if there is a required or suggested timeline for consumers to request language access services, that be included on the one pager.
Arthur wants to say this is contacted with his issue.
This is connected, yes, to having personal assistance.
Yeah.
Yes. Yes. And Arthur, if you have something to add here, you know, it would be good to have your input.
No, you said not now?
Okay.
Not now, yeah.
And it may be that having another one pager for verbal needs, or you know, having an interpreter, not for other languages, not deaf or hard of hearing, but for other, you know, language needs would be helpful. So I don't know if you have thoughts on that, Arthur, but we
Yeah, yeah. You say yes? I know. I am? You wrote about it? Yeah. You say you wrote about it. I am? Yeah. Yeah, it says writing about it.
you're writing about it. Okay.
Yeah.
So that could be something that we discuss on our August agenda as well. So for other
Yeah.
communication needs.
Yeah, and Emily, can I chime in too?
Yes, please.
Having lived a long time with a loved one that is nonverbal or minimally verbal, thank you for bringing that up, because I think what Arthur probably will, you know, give us guidance, but I just think we need to be inclusive, because oftentimes those individuals would need to have the support of an assistant or guardian, and I think that would be just really wonderful.
Right. Not an unknown professional who would be
Yeah.
able to interpret for them, but someone who
Yeah.
knows them and knows how they communicate, right?
Yeah, because as a mom, I've had to go in and kind of pave the way, and but not, you know, I won't be here forever. So I think having the opportunity to have support, you know, or respect for when somebody comes in and serving that purpose would be just so greatly appreciated. And we have children that are nonverbal as well too, that, you know, look to their parents to help share that information.
Right. Well, I would really look to you and Arthur to provide some input or suggestions on what you think needs to be on a one pager related to, I don't know if, you know, thinking of it as limited verbal skills or nonverbal, you know, is the right way to kind of think of this separately from other language needs.
Yeah.
But having something separate that we could discuss in August.
Okay.
Yeah, thank you. Any questions about the feedback that we provided on the one pager that we just reviewed? Questions from DMS?
Just need them in writing.
There you are, Angie. I wasn't sure if you were on or not, so good to see you.
Yes,
Yeah,
ma'am.
you do need them in
Just
writing,
listening.
you said?
Yes, I just need to see in writing what you're recommending. We'd have to look and see what we can and can't do and involve MCOs where we can in developing
Okay.
these. So
Well, I have one recommendation that I've kind of drafted, and then it sounds like Miranda's put some in email, but we can also include them as more formal recommendations if that would be helpful. So we can do that when we get down to that part of the agenda. The next item here is the Beneficiary Advisory Council. And I know that, you know, the deadline for applications has passed, and just wondering what next steps are at this point.
Yes, happy to give that update. We had 34 applicants for the back, which we were very excited to receive, a mix of member, former member, current member, former member, parent, guardian, and caregivers. So we are currently going through the applications. We are, as I've mentioned previously, really trying to make it as diverse as possible. So we're trying to look for representation across the state. both in gender, race, and ethnicity. So those reviews are going through right now. And of course, we're doing this in concert with also selecting the applicants for the the new Medicaid Advisory Committee. So we are on track. Our goal was to have this done by July 1, and we are on track, I think, for getting those applicants selected. And we will, I do want to note that based on the federal rule, a BAC, a Beneficiary Advisory Council member, can choose not to share their name. And so once we choose choose the appointees, we will be reaching out to them to find, what kind of walk through those types of things. So we don't want to post their name if they want to choose, take the option to not have it posted. And then we are creating an orientation. We've never done that before. So we're doing creating an orientation, and we'll be doing an orientation pretty quickly for those folks. The other thing we'll be doing is reaching out to them and finding what needs what support they may need, such as translation services, language services, personal needs, assistant services, transportation, just sort of having that conversation to address their individual needs and to provide as much support as we can to help them participate. So we are again on track for kind of that early July appointment.
That sounds great. Yeah, I would love to see the orientation and, provide some input on it if we could do that as a consumer TAC.
We are quickly trying to finalize it, and could during an interim send that to you like we've done.
Email.
Yeah.
If that would be okay.
Certainly happy to share that with you all for review. You all generally do provide really great feedback to us on our communication, so happy to do that.
Great, thanks. Well, we're excited to see this get started. And if I recall, it sounded like the first meeting would probably not be until September. Is that right?
That's likely just from, I'm sorry, Arthur, just from doing that orientation. We want to schedule meetings that are convenient for the members, not for us, but for them. And so we're going to work really hard to accommodate their schedules and their needs. So that's why we think it's probably going to take, at least a month or two to get us all together and have those conversations and choose those dates. But we are hoping for September.
Yeah, sounds
Yeah,
good.
Arthur, I want to say, says someone's supposed to call him tomorrow about this.
Yes.
Mm-hmm.
Very good. And just as another reminder, assuming that the consumer TAC or the beneficiary advisory council does start meeting in September, August would likely be our the last meeting for the consumer TAC, and we would suspend our meetings assuming that the BAC continues to meet. So just want to keep putting that out there so that people remember that. So bring all your good ideas to the August meeting. All right, our next item here is under new business. I think we're at that point now. There's a CMS proposed rule on provider taxes. And while that's what I put on the agenda, now that we have the Senate version of the reconciliation bill, the One Big Beautiful Bill Act, that does include some provisions that I think will directly impact Kentucky provider taxes, assuming it goes into effect. I wonder if you could speak to both of those.
Steve Bechtel, Chief Financial Officer for the Department of Medicaid. Yeah, Emily, it's hard to say because nothing's final just yet. But what is proposed in the Senate's bill would decrease our provider taxes on a few. But I will say that it starts decreasing from the 6% hold harmless, which is the maximum of 6%. Starting in federal fiscal year 27, it decreases 0.5% each year until it reaches 3.5% is the maximum. But that excludes, I believe there's language in there that excludes nursing facilities, and I believe ICF, IDD provider types. So that would exclude both of those that we currently have. What that would include, though, is like our ambulance that we have a directed payment for. Of course, there's also language in there around directed payments as well. So we'd have to tie that together. Our for this, it'd be our supports for community living provider tax that we have in there. It would be lowered from the current 5.5 over the several years to 2031. It would be lowered down to 3.5. So yeah, it would be impactful to our hospitals and our SEL providers, as well as the ambulance.
Yeah, thank you. I mean, it's hard to hear because I know that could really reduce access to care in a significant way. But it's also good to know that specifically what it would impact and what it wouldn't. Do you have any estimate on like the dollar figure that this, once the difference between what the provider taxes are for each of those types of provider, if it were to go down to 3.5% eventually? Or is that something you're still working on?
I've done a little. Now this is very, very it's not final yet, I should say, but the ambulance would lose about 4.8 million if it went down to 3. That's in state funds, right? So that would be what, 16 million at the or I think it would be let's see, it'd be almost 20 million if I was drawn in at the 20% FMAP. So that's 4.8 for that. And the SCL would be 7.3.
7.3 state funds for SCL.
Yep.
And then do you know for the hospitals?
The hospitals is hard to understand, hard to look at, because currently in our provider tax amount is included the HRIP funds, the hospital rate improvement program. But the hospital rate improvement program is on an average commercial rate. And as part of this bill, it eliminates the average commercial rate by like 10% a year to get down to the Medicare rate. So that one's a little more, that's the one I'm still working on of trying to determine. Now I can tell you currently we do have a 2.5%. If let's say hospital rate improvement program was not even in the picture, we would still stay at the current amount, because we're paying the hospitals pay a 2.5% tax, but it's on their 2008 or 2007 revenues per the statute. So that would not change. We would still be getting the same, because it's 2.5%, and that would be lower than the 3.5% maximum.
So it's not the provider tax in that case, but the
HRIP. It'd be the directed payment that would be costly. I have done some numbers on that. The directed payment for hospitals, we currently pay a total of about 4.6 billion a year in our 4 directed payments, and that's including the ambulance providers. But if we go down in the Medicare rate is the full amount, and that's looking at just the current year, we would lose about 4.1 billion of that 4.6. So only about 500 million would still be going to these providers.
Oh, wow. Okay.
So what that does is for hospitals, it removes, and for the hospitals, they make up 4.5 of the 4.6 billion. So it'll be very impactful to the hospitals. But they would then be able to get dish payments that they're not getting now in the disproportionate share hospital. But I think my total allotment for that is like 240 million. So it's a drop in the bucket compared to what they're getting in the directed payments right now. So it would be very harmful, I would think, especially to our rural areas, as well as it could cause some access issues if it puts a few of those hospitals into dire situation on financials.
Wow. Okay. Thank you for that. That is that.
Emily, can I ask a question?
Yes, please.
Is there anyone who could speak to the proposal of the work requirement in the big beautiful bill with Medicaid? And who do you think would be exempt from those work requirements?
Yeah, Brenda, I think that's a really good question. I want to, before we move on to the work requirements, Steve, is there anything else in the proposed rule? So not the Big Beautiful Bill Act, not budget reconciliation in Congress, but CMS's proposed rule that would have an impact on provider taxes that you could help us understand?
No, that proposed rule was about looking at the uniformity of the tax to make sure that there's no that did not apply to us. That was, I'll be honest with you, that was mainly written to address Michigan because they had some how can I say it, inappropriate provider taxes that they were doing.
Okay, that is helpful.
Yep.
Okay. So you think that it's really the
Well,
reconciliation
it's
bill
also
that-
addressed in the Senate's version of this bill under section 71-122. So, but it's basically just saying that they want to make sure that the waiver, and I'm going to say some things that maybe it's not, it may be too weedy here, but the B1, B2 test that we have to do to prove that it's uniformity, that we have to submit to CMS, they're basically, laying out in this bill what qualifies and what doesn't. But as we read it, it's not going to be impactful to the Kentucky Medicaid.
Okay.
The only one I was concerned about was the nursing facilities because it is a tiered system based off of bed days. So I was trying to determine if that was going to be impactful or not. But what I'm being told from some of my consultants is that it will not impact Kentucky.
Okay, that's good to know. All right, thank you.
And as far as the community engagement, it is also in section 71124 of the bill. It goes through those exempted populations. To answer your question, it's people, I can read it to you. It's veterans with a disability, individuals who are medically frail or otherwise have special medical needs, individuals who are blind, who have a substance use disorder, a disabling mental disorder, a physical or intellectual disability that impairs their ability to perform one or more of the activities of daily living, or a serious or complex medical condition. Parents, guardians, and caretakers, caretaker relatives of children age 14 or under, or a disabled individual. Foster care youth through the age of 26, individuals who are Indians, urban Indians, California Indians, and other Indians who are eligible for the Indian Health Service as determined by HHS Secretary. And then the last one is individuals who are inmates in a public institution or who were inmates in a public institution at any point during the 3-month period prior to the month. That's hard to prior to the month where the compliance with community engagement activities is being verified. So those are the ones who are being excluded from this. If this goes, again, I have to preface that this bill has not been finalized, but as part of the proposed bill from the Senate, that's what is there. There's other qualifying events, the things that qualify is to be a student So I guess you would be excluded too if you're a student, but you have to prove that you're to being a student. And
That's exactly what I was going to say, Steve. I think
yeah,
that the proof, and that's true for most of these exemptions. Now,
yep,
for foster youth, the state may be able to identify those individuals and automatically exempt. Even for parents, though, you've got head of household, but that might not be the primary caregiver that needs to be exempt. And so I don't see there being an automatic and really accurate process that the state could do without it requiring some documentation by the individual. And I worry that particularly the way that it's designed, that you have to prove this at least a month prior to enrollment or renewal. So for individuals who have been uninsured, or maybe they have a new condition, they're unwell, maybe they have an injury, maybe they have an untreated, undiagnosed substance use disorder, or some other condition. When we expanded Medicaid, I remember that we had a big surge in people getting diagnosed as diabetic or with
yeah.
cancer. Who
And I'll just tell you too, Emily, is back in, I was here when we tried to go down this route before under Governor Bevin at that time. And you're hitting on a lot of the headaches that we had then is how do we verify the information? How do we receive the information appropriately and accurately? And in what form, how will people do it? Not everybody has internet, so how do we get that information into the system? Those are all questions that we have here in the department as well. So it's concerning. We are concerned about this because we feel like sometimes people may be wrongfully terminated, even though that they've done their due diligence, and but it's just the system's not taking it, and that's my concern.
Yeah, I share that. Brenda, did you have any more questions or something else that you wanted to add here?
No, that kind of gives me an idea who would be excluded. I'm just wondering if an age requirement, if someone is over 65, would they automatically be excluded?
Oh yeah. It's only all of this. I should have led for that. It's only for people who are non-pregnant, non-disabled, childless adults from the age of 19 to 64.
Okay.
Emily, this is Leslie. I was just going to remind everybody that our proposed community engagement does not match that bill. I just wanted
Right.
to throw that out there. It doesn't even
Yes.
match the ages are even different. So just wanted to throw
Yes,
that out.
thank you for bringing that up, because of course, all of this happening at the same time, I think there is a lot of confusion, and we saw in the comments that we collected that people were definitely conflating the two. Even though in our comment collector, we literally spelled out the differences and made sure one said
Yeah.
no penalties, to try to prevent that from happening, so that people weren't going to have that fear, that uncertainty.
That's correct. And we plan to develop some type of self-attestation process. And then, of course, ours is not punitive in nature.
Right. Which we really appreciate.
So
Yeah.
Ms. Menino, I will just make sure I'm clear. Is only those that are between the ages of 19 and 64 are subject to the work requirement, as far as per the bill that we were talking about that the Senate has just posted out Friday.
Yes, and good point that you made earlier. This is just proposed. This has not been finalized. I think there are a lot of legislators that are very, very far apart on this.
Yep.
And it's really up to us right now to be reaching out to our members of Congress to let them know what we think about this proposal and how it would impact Kentuckians. I will just drop in the chat. I don't know if this will fit in the chat. Actually, yeah, let me see if it does. I'm copying what we had included in our comment collector as our explanation of the differences, because I think it really is quite confusing. Let me see if this comes through. Okay. Oh, I'm over the limit. I'll have to send it in an email. But I can do that, Brenda.
Emily, I can share my screen real quick. I pulled it up so you could see it. I know it's confusing right now that it doesn't match exactly. And it's not punitive in nature and all those things, but even the age doesn't work. If you can see my screen, individuals under 19 or over 60, that's even different. The tribal information, of course, is not on here. All other good cause exemptions as approved by our cabinet, and that would be through a self-attestation process. So we even included natural disasters, deaths of family members living in the same households, caregivers.
Yeah, thank you.
Just sharing.
Yeah, no, that it is
Thank you.
helpful.
Yeah, that is.
Any other questions about what's being proposed either in federal rules or the reconciliation bill? Okay. We can move on to our final item before we get to recommendations. Behavioral health prior authorizations. We know those are going back into effect, and there was talk, I think, on our last call about some communications and outreach to members, and I wanted to follow up on that.
Well, from the DMS side of things, we just posted a
Go back.
behavioral health
Uh,
MCO
uh.
comparison of what they are prior authorizing starting June 25th. All the MCOs have been meeting with providers and educating, and obviously they can talk more to what they're doing on that end, as well as all communications regarding this should have been out to providers 30 days prior to the start of the behavioral health prior authorizations. But we just posted today the comparison of what each MCO is requiring for prior auth. I believe Aaron shared that with the TACs as well.
Did you say that was today?
It went
Yes.
out this morning.
Okay, I need to check my email, but thank you.
And I mean, it's on our website, and I can post that link in the chat.
Sorry if you've said this already, but what is the reason for the change in the behavioral health prior authorizations?
House Bill 695.
Thank you.
Yeah. So Miranda, that bill is essentially requiring that prior authorizations that were in place before the pandemic, January 2020, January 2020, are reinstated. Although the way I understand, I mean, that language to me is a little different than how it is being implemented, which is the MCOs are now able to either put a prior authorization on a behavioral health service or remove one. It seems like MCOs have the discretion to remove PAs even if they might have had that PA in place in January 2020. Am I right about that?
That is correct.
Which I think is better, just to be clear. But that's
Well,
not
United, yeah, and United wasn't an MCO at the time either,
That's
so
right.
they wouldn't have anything to reference back to that. But yes, they can put into effect what was in effect 1/1/20, and they can make changes to that as well if approved by DMS. And so whatever they have put it forth to the providers and any education, it has been approved by DMS. Now, that doesn't mean that everything will remain the same, but right now that comparison is what we have for each of the MCOs and what they are requiring, and in certain areas where there are billing limits as well.
Right. All right. And those behavioral health prior authorizations aren't limited to a particular population or age group or anything else. So
No.
Just basically putting it back in the hands of the MCOs.
That is correct.
Any other questions related to that? All right. Well, we can talk about recommendations now. I've got one, and Miranda, do you want to make recommendations from what you said earlier related to language access?
Emily, this is Erin. Before you get started, I just want to give you guys a friendly reminder. If you do make recommendations, they will be held until the next MAC meeting, which we're hoping will be in September. So I just want to let you know that if you do make a recommendation, it will not be turned around in the 45 days because we won't have a MAC meeting until September.
Right.
Just
Okay.
throwing that out there.
Erin, I did think that there was an effort to schedule one for
They
July.
were unable to get a quorum, so that's the MAC for July has been canceled.
I see, but there won't be an issue with the change in members to wait until September.
I assume come September when the first MAC hits, they will be taking recommendations, excuse me, but Veronica, if you're on,
Yes, we'll definitely have it as an agenda item. And again, that'll be part of the orientation is to make them understand the framework and the process. And so we know because there'll be a gap, a couple months of gap in between the last meeting and the next. We're gonna make sure it's an agenda item. We're gonna ask the members to put that on the agenda so that they can be taken care of. And I will say, we'll have, you're making your recommendation, we'll have it. We always have our discretion. If there's something that, especially if it's, time sensitive, that we could go ahead and take a look at, and to just kind of go through the more formal process.
Right.
As soon as the new MAC is meeting. But yeah, that'll be the process.
thank you, Veronica.
Yeah,
I
thank
just
you.
wasn't sure since it was an ongoing issue that you guys were going to make the recommendation on the one pager, if you wanted to kind of do that informally, since there's going to be a wait. I just wanted to make sure that the TACs are aware of that when they make their recommendations. I don't want
Right.
somebody sitting around waiting going, why is she not sending me information back yet? So
Yeah.
Well, I guess I'll ask that of DMS, like Veronica, Angie, would you rather we make these informally? I know Angie asked for them in writing, which we can do whether we
Yeah.
submit them as a formal recommendation or not, but would there be a delay caused by us making formal recommendations versus not?
I think the way I may respond to that is, we don't need a recommendation for some, recommendations are really helpful to us if you really talk about changing services or eligibility or benefits or, substantial policy changes. I think a request for us to put something, communication is very different and happy to take that informally.
Okay.
It really doesn't need a formal recommendation.
Well, I will just, I'll read what I have here and then I'll put it in the email that Miranda has already sent with her recommendations, just so that you all hear it, everyone who's been part of this conversation. My recommendation would be that DMS develop language access one-pagers tailored to providers and beneficiaries individually. And include on both one-pagers the number to call to request an in-person interpreter and the language line number for phone or virtual interpretation, which is essentially just summarizing what I've said earlier. So I'll put that in email. It looks like somebody just posted a comment. Let me see. Oh, maybe not. Something else flashed on my screen. Okay, Miranda, is there anything that you didn't put in email that you wanted to bring up now?
Don't think so.
Okay. And then any other recommendations on any other topics that we've discussed? All right. Well, hearing none, I think we can move on to the final couple of items here on the agenda. As usual, I will represent the consumer TAC at our upcoming MAC meeting, assuming that one is in September. And as far as our meeting schedule goes, while we have meetings scheduled for the rest of the year, I'm going to assume our final meeting is August 19th, but I think we should keep October and December on our calendars for now, until we know that the back is up and, actively meeting. And at that point, we can cancel those meetings if they're no longer needed. Does that sound okay? I'm seeing a little bit of head shaking, so I'll take that as a yes. And with that, I think we can adjourn by acclamation. That's, I think, what I do most of the time. I get some of my meetings confused. It was good to see everybody. Thank you all. And hopefully I'll see you in a couple of months. Bye.
Thanks, everyone.
Okay, bye-bye.